Hey everyone, Dr. Matt Geller here. Hope you've been enjoying the show. That last session, absolutely loved it. Hot topics in glaucoma, really phenomenal stuff. My next guest is Dr. Mike Ammar. Super excited to have him on. Let's bring him in. Hey man, how are you?
Hey Matt, how you doing? Thanks so much for having me.
For sure. How are you enjoying the show?
It's been an awesome conference. Great talks, great speakers. I'm really excited to be a part of it.
Yeah, absolutely. Wouldn't be the same without you. So for those that don't know you, if you can give just a brief introduction, some background on yourself, and start there.
Yeah, happy to. Did my medical training out in Los Angeles at USC, and then came out to Philadelphia at the University of Pennsylvania Shea Eye Institute, and I did my ophthalmology residency there. And I just wrapped up my retina fellowship, my surgical retina fellowship at Wills Eye Hospital, which was a great experience. And excited to be coming back to Southern California now, to your town. I'll be heading to San Diego, joining the retinal consultants of San Diego with Nick London and so many other great people. So really excited about that.
Yeah, for sure. No, it's a really great practice to join. There's no doubt about it. Nick's a good friend of mine, although I'd like to see him more. Hopefully he's watching. Hey, Nick. No, and for all the ODs out there, I'm sure they're really excited to hear more on this topic because, retinal surgery and glaucoma, you may not, when we first talked, we were like, hey, where can we take this? What's the direction to go here? And maybe a good place to start is just types of glaucoma you may see after retinal surgery, and just feel free to kick it off. Yeah.
Yeah. So, like you said, I mean, at first glance, people may say, well, what does retina surgery have to do with glaucoma? And just as kind of a broad overview of glaucoma, I mean, glaucoma is an ever-growing issue, as we know. An increasing number of people, millions of people, are having vision loss related to glaucoma. And there really is a lack of education for these patients in regards to the consequences of untreated glaucoma. And it is so dangerous in that the vision loss can be slow and occult. And sometimes they don't really even realize they've lost vision until they've had pretty substantial losses. There are many categories of glaucoma and approaches, but what's relevant to myself as a retina surgeon is the management of glaucoma in the postoperative period. It's more diverse and complex than many people might imagine, and there are so many different types. But one area I'd like to talk about really is if you break it down, it's still kind of like two categories, open angle and closed angle glaucoma, and that keeps it pretty simple. But oftentimes these patients can develop vision threatening diagnoses that require immediate management. And they're not always presenting to us. They're often presenting to their eye doctors, their optometrists, before they present to the retina office with eye pain. And so we're really lucky to have such great colleagues who are often making the diagnoses that are vision saving, and it's really a team effort. To get back to your question for the categories, I said, like I kind of mentioned, I think it's easiest to break it down into two areas. First, open angle glaucomas, which we see after retina surgery. So gas or silicone oil overfill is a major issue. It's uncommon, but it can happen. In general, following retinal detachment repair or macular hole surgery, or some other surgeries even, a tamponade agent is used to fill the vitreous cavity. This can serve different functions, but often is a way to support the retina as it heals. When these agents are instilled in the eye, the intraocular pressure is checked really by finger tension or digital palpation. So as you can imagine, sometimes these eyes can be accidentally overfilled and result in significant increases in pressure. A second cause that we often see is gas overexpansion. So this can be quite dangerous. Pure gas is expansile by nature. However, in general, when we fill the eye with gas at the end of a case, we prefer it to be non-expansile, barring some specific procedures and situations. To do this, an assistant or the surgeon will actually dilute the gas at the time of surgery to an isoexpansile concentration. However, if this dilution is incorrect, the gas may still be expansile. So while the eye may feel normal after surgery, the patient may go home feeling normal. It will slowly expand in the eye as a relatively confined space, and the patient can develop a dramatic increase in intraocular pressure. Another cause is emulsified silicone oil. So the silicone oil we put in the eye is kind of a cohesive element held together by surface tension as one sort of big bubble. But over time, it can break down and emulsify into small little bubbles that can migrate to the anterior chamber. This can form a very classic sign called a reverse hypopyon because it has the appearance almost of a hypopyon but because the bubbles float, is actually in the superior aspect of the anterior chamber. These bubbles can plug the angle and lead to increases in intraocular pressure. More familiar causes are steroid response from patients being on topical drops, which can be seen after so many surgeries, or inflammatory debris if patients have very complex cases, such as retained lens fragments or trauma, things like that. I think those 5 are some of the most common, not all comprehensive, and some of the most dangerous we see right after for open angle glaucomas in surgery. Some of the more common causes of closed angle glaucomas would be ciliary body edema or rotation, which can happen following a scleral buckle. Uncommon, but possible. One really dangerous situation is a pupillary block with silicone oil in aphakic patients. And then a growing surgery for retina specialists is secondary intraocular lenses. If patients have a dropped lens or a loose lens or a traumatic lens, we can remove the lens and suture in or scleral fixate another lens in its place. Studies are coming out that are showing that there's a small rate of pupillary block associated with these lenses. And so, again, this isn't a totally comprehensive list, but some of the most common and some of these quite dangerous causes of postoperative glaucoma in retina patients that we see and often are co-managing with our optometry and glaucoma colleagues.
Got it. Yeah, very thorough. I appreciate that for sure. And I think, for ODs out there, it's a really important, kind of message to heed, because if you're seeing a post-op and you're wondering, hey, this pressure is pretty high, those are a pretty good list right there of where you can begin. What's the most common one, do you think, that an OD would see after, say, post-op surgery, or that might end up in their chair?
I would say the most common would probably be an overfill of either gas or oil, which oftentimes can just be medically managed with drops, rarely temporarily Diamox. Thankfully, gas by nature gets absorbed naturally into the eye, so if you can wait it out, you can avoid having to do anything more invasive. Unfortunately, oil does not, and so if it can't be managed, it requires a trip back to the operating room to remove the oil. You can actually remove some of the gas if needed in the clinic with the procedure, just by sticking in a needle and syringe and what's called tapping off some of the gas. But I'd say that's probably the most common.
Got it. So when thinking about management approach for those, kind of top list items you listed there, how would one think about management?
Yeah, I guess to go over a few of the more dangerous and the most common ones, incorrect gas concentration can result in incredibly high intraocular pressures that may result in permanent vision loss and optic neuropathy. This is due to the concentration becoming expansile when it shouldn't be. This phenomenon can actually also be seen if the gas is done perfectly, but the patient goes to a high altitude, as little as over 2,500 feet, or flies in planes, which is why we ask them not to travel, or even using nitrous oxide anesthetic in a dental office. So there's actually a lot of situations where gas can be dangerous. And because of that, patients will be given a green medical wristband typically that they'll wear till the gas is gone. The management, like I had mentioned, is often medical first if we can, depending on how high the pressure is. And then if needed, a procedure to remove the gas in the office. But gases can also be at the perfect concentration and just be overfilled during surgery. Again, the management is medical if possible with drops, rarely oral medications such as Diamox, and then if needed, procedural treatment to remove the gas. Oil, similar, medical if possible, but unfortunately there isn't really an office-based procedure to remove oil because it's so viscous. It actually requires a trip back to the operating room. Angle closure from silicone oil is a very interesting situation because at the time of surgery, if a patient is aphakic, the oil can plug the pupil. We do a surgical iridectomy, just like you would do a laser iridotomy. It's the same concept, inferiorly to make an opening, but that can scar over time. And so patients can develop a pupillary block, and the definitive treatment in the clinic would just be to do a laser iridotomy inferiorly. Of course, medical management can help get them some time.
Got it. Now, do you do that inferior LPI because it raises to the top and is more likely to... How come the inferior location there? Just curious.
Yeah, no, that's exactly right. So the oil or the bubble by nature floats kind of like with gravity, anything in a bottle of water, wherever the most superior aspect is, it's going to float. And so we generate that inferior iridotomy so that aqueous production and fluid, which will settle inferiorly, has an exit strategy to get out of there and not just keep building up pressure behind the pupil.
Got it. Like you were saying with that kind of flipped hypopyon sort of thing.
Yeah,
Interesting way to think about it. What about kind of situations that arise more long-term and that don't require, say, an immediate visit to, tap it or whatever it might be, but I guess situations that, are less acute and maybe build in pressure over time?
Yeah, so emulsified silicone oil is an interesting scenario. The situation you're just referencing, the oil can break down over time, essentially. When we put in oil into the eye, we leave it in with a plan of about 3 to 6 months. But patients can sometimes be lost to follow-up, or if they have a lot of inflammation in their eye, the oil can break down into small little bubbles and migrate into the anterior chamber. And that's something that may not happen for months down the line. Non-emulsified silicone oil can also migrate. Little globs can move into the anterior chamber. And so that's a cause sometimes we see way down the road. Steroid response, again, from drops often happens in a more delayed fashion. And then inflammatory debris can sometimes present itself later if the angle is clogged up from a lot of redetachment surgeries or traumas or complex surgeries.
Mm-hmm. Are there ever situations where maybe someone has had a glaucoma surgery and it affects just the way you're doing buckles or different retinal repairs, maybe closer to the aura? I mean, clearly it's more of an anterior seg thing, but just curious if that kind of comes into play in the way you either prep for surgery or whatever it might be.
No, that's a fantastic question, and actually does require a lot of co-management with us and their glaucoma specialists because it can be a major factor in our surgery. So, retina surgery depends initially on the implementation of trocars into the eye. So we have access points to stick our instruments into the vitreous cavity. And if the patient has a tube or if they've had mixed procedures or things of the like, we want to work around those items. And so we often will speak to their glaucoma specialist to ask where they feel most comfortable with us manipulating the conjunctiva, because that conjunctiva might become scarred down and sort of unusable in the future if they need additional surgery or tubes. So that's a situation. The kind of tamponade we put in the eye can matter. So oil can plug tubes. So sometimes we're in conversation with them about what kind of tamponade we should use. Sometimes we do conjunction surgeries where we'll actually clear out the vitreous so they can put the tube in the vitreous cavity. So really, it's actually quite a number of situations where it matters. So if a patient has glaucoma, we are actively involved with their glaucoma specialists.
Yeah, that's super interesting, especially if it's like an acute something going on with the retina. Then you've really got to get on the phone quickly. And what about would it ever be a situation where, hey, we've got to do something retina-wise, and that opens up a good opportunity for a glaucoma surgeon to either modify something or maybe not a good opportunity, but would that change the way a glaucoma surgeon would maybe do their care if they have yet to do a procedure or they have a desire to modify maybe a procedure that it's already been done? That one might be a little more tricky, but I'm just trying.
No, I mean, these are fantastic questions. And yeah, it's actually excellent insight. So one very common situation is almost always if we're doing a retina surgery, it means we're starting with a vitrectomy or removing the vitreous gel. Mm-hmm. And that can be a nice place to place a tube. The anterior chamber can be very crowded. You have so many structures in such a small area. The vitreous cavity is quite large. And so glaucoma specialists sometimes really appreciate having the opportunity to place their tube in the pars plana, or the vitreous cavity, basically, through the pars plana. And so if they know we're going to be doing a surgery, it's not uncommon to do a combination surgery where they sometimes will place the tube in the vitreous cavity, or even request just that we do a combination surgery with them to do a vitrectomy so they can put it in the vitreous cavity. If, for example, a patient has a very shallow anterior chamber, a short eye, these are some examples where they'll have us get involved.
Yeah, love it. It's certainly collaborative. There's no doubt about it. Yeah, all these ideas are coming to mind like, whoa, this opens up a whole new, I guess the more difficult cases. And I'm sure you got to see a lot of that cool stuff at Will's, I'm guessing. Were there cases you had that were similar?
Yeah, I mean, we're very fortunate to have a great hospital and incredible volume and great colleagues, from optometrists to ophthalmologists, our glaucoma colleagues. And I mean, every given week, we're often doing combination surgery with our glaucoma colleagues to some degree, whether it's removing a lens that's too unstable to remove by cataract surgery, and then they come in and they'll place the tube, and then we'll come back in and place that secondary intraocular lens. Sometimes just removing the lens itself can drop the intraocular pressure. And so they'll just watch us do our surgery and hold off on anything. But we often are working in conjunction, doing combination surgeries with a lot of departments, but glaucoma is very common. And that situation I see very often, us doing the vitrectomy in anticipation of a pars plana tube.
Got it. Interesting. Yeah, for sure. Well, any last comments, things you want to touch on? I really appreciate it. Super, super helpful insight. I think we're at the kind of the I don't know what you'd call it, but out of everything discussed at this show, this is probably the most complex situation you could get involved with, is a retina glaucoma a conundrum there. We should do a whole session on that.
Yeah, I'd love to. I know it's sort of a small niche piece compared to all these great high yield topics you've been going into, but hopefully people find some of this to be helpful. Surgery can be so rewarding because we're able to help so many people preserve, improve, and save their vision. But it is also humbling and complex, and it really requires close observation in the postoperative period to ensure maximal success and impact and benefit for our patients. The truth is we could not do that without the entire care team of our patients, which often and typically involves optometrists and other specialists such as glaucoma doctors. And really, optometrists are the frontline people who are seeing these issues first present, kind of like you alluded to. A patient has a painful red eye, they may not know what it's related to, and they don't go to the retina office, they go to their eye doctor. And so that triaging and initial treatment and management is often happening in those offices, and that critical communication and collegiality and teamwork is happening, all generated by the optometrist. So I just feel very fortunate to work with such fantastic colleagues who do such an incredible job of this. I'm really grateful for all the work they do for our patients and the eyes that they save. And I just want to thank you for the privilege of joining for this event. I mean, really incredible job by you, Matt, and the entire Eyes On team. Wonderful talks, wonderful speakers and discussion. I've really enjoyed it. So thank you, and look forward to hopefully seeing you soon out in San Diego.
Yeah, no, absolutely. Thanks for that. I appreciate it. Yeah, when you're out here, we'll definitely grab some lunch, and you can meet some of my OD friends around here, and I know it's going to be, you'll be a great addition to the San Diego community, so looking forward to it. But thanks for coming on, and for everyone else out there still watching, we've got a little bit more content left before we wrap up. Make sure you check out the conference bag. We've got our 2021 glaucoma report in there. We're giving away $1 to charity for everyone that clicks the button. I think we're almost up to like $1,500, $2,000, maybe something like that. But head in there. And Dr. Ammar, thanks again. Appreciate it. And talk to you soon.
Talk to you soon.
Okay.
Thank you.
Bye.